Bismillah, wassalatu wassalamu ala Rasulullah. In the beginning of this webinar, it's my honor to welcome everyone who joined us this evening. Also, I would like to express my gratitude to the Saudi General Surgery Society, represented by Dr. Ashraf Maghrabi, the President, and the Deputy President, Dr. Yusuf Alawi, for their tremendous support to initiate the scientific activity in our Saudi group of thoracic surgery. Also, will not forget the Johnson & Johnson for their generous support to make this event happen. We'll start this evening or this webinar by a brief speech from Dr. Yusuf Alawi, who's the Deputy President of Saudi General Surgery Society and consultant of breast and endocrine surgery and head of Department of Surgery at King Salman Armed Force Hospital in Tabuk. Please go ahead, Dr. Yusuf.
Thank you, Dr. Saleh. First of all, I want to thank everyone joining this webinar. On behalf of the Saudi Society of General Surgery, I want to welcome all of you in our monthly educational meeting. And this night, we have distinguished speakers from Saudi group of thoracic surgery. And as usually, we're enjoying the topic and really very thanks for all of the moderator and the speaker. Thank you, Dr. Saleh. As Dr. Saleh, he will be the chairman of the webinar. Dr. Saleh Al-Nasr, he's a consultant thoracic in King Saud University. And please feel free if you want to ask any question, the A and Q. Yes, Saleh.
Yeah, thank you so much, Dr. Yusuf. So before starting the first session of this webinar, I'm glad to announce that this webinar will be taking place annually. Every year we will choose a topic and we'll have speakers to talk about it. Then we'll listen to the experts in the field and try to have a discussion and learn from each other. So I highly encourage everyone to participate with us tonight. Also, I want to remind the speakers and the moderator to be cautious about the time, in order to get the max benefit of this webinar. So without further ado, we will start with the first session with Dr. Ashraf Maghrabi, who's the president of Saudi General Surgery Society and an associate professor and consultant of thoracic surgery and thoracic and foregut surgery at King Abdulaziz University. Please go ahead, Dr. Ashraf.
Thank you so much, Saleh, and thank you so much for the panelists and the audiences for being here tonight. It's my pleasure today to be the moderator for the our first presentation, who will be given by our friend, Dr. Soha Kaki. Dr. Soha is a thoracic and foregut surgeon at King Saud University Medical City at Riyadh. She's currently the program director of Thoracic Surgery Fellowship. She's an assistant professor of surgery at King Saud University in Riyadh, Saudi Arabia. She obtained and she done her general surgery residency in University of Manitoba, Canada, and where she had also Canadian and American board in general surgery, then followed by thoracic surgery fellowship in University of Ottawa, Canada, and she finished her training with a fellowship in robotic and minimally invasive thoracic surgery at Duke University, US. Without further ado, Dr. Soha, the floor is yours.
Thank you, Dr. Ashraf, for this generous introduction, and thank you for giving me the chance to present today and be a member of this marvelous panel of speakers and moderators. Today, I'll be talking about the fundamentals and rationale of lung cancer screening. I have nothing to disclose. So the objectives of my talk will be to review the past, talk about the present, and hope for a better future. Why do we care so much about lung cancer screening? Lung cancer is curable at earlier stages, so their survival can be more than 80% in stage 1, but it drops to around 30% or less in stage 3, and even less than that in stage 4. It's the leading cause of cancer death for women and men. Lung cancer is the second most common cancer worldwide. It's the 5th in men and the 13th in women in Saudi Arabia. In 2020, there was an estimate that more than 200,000 persons were diagnosed with lung cancer, and more than 100,000 persons died of this disease. We always hear or we heard about breast cancer screening and colon cancer screening before, but lung cancer screening always lagged behind. And the reason behind that is the studies that that included lung cancer screening in the 1970s used chest X-rays and sputum cytologies. And these studies showed no benefit of lung cancer screening utilizing these modalities. In addition, there were concerns about the availability and cost of CT scans, plus the safety of the CT scan radiation dose was questionable in this high-risk population. So I'm going to start by reviewing the National Lung Screening Trial and the Nelson Trial, which were the only trials that were adequately powered to detect lung cancer mortality benefit. The NSLT led to the implementation of lung cancer screening in the US in 2015. It was published in 2011 in the New England Journal of Medicine. This is an overview of the study. So it was a randomized controlled trial, which is the highest level of evidence. They compared the control group to the experimental group. The control group underwent annual chest X-rays for 3 years, and the experimental group underwent annual low-dose CT scans for 3 years. They enrolled patients from 2002 till 2006, and they had the follow-up till 2010. The primary outcome was lung cancer mortality assessed after 5 years of follow-up. They included patients with the age range of 55 to 74 years, with a smoking history of at least 30 pack per year, who were currently smokers or former smokers who quit within the past 15 years. They enrolled around 53,000 participants from 33 sites. The results showed that there was a 20% decrease in lung cancer mortality and a 7% decrease in all-cause mortality. And these numbers just showed the reduction of the lung cancer mortality, which was 20%, as we mentioned. The NSLT was the only study that has shown statistical significant reduction in total mortality, which was around 7%. Lung cancer was the cause of death in 22% of the patients who underwent screening and 25% in the patients who did not undergo screening. So we can see here that the lung cancer caused more death in the patients who were not screened. The incidence of lung cancer was around 650 cases per 100,000 persons per year in the screening group and 570 cases per 100,000 persons per year in the control group. Again, the incidence of lung cancer was higher in the screened patients. An analysis of the NSLT results revealed that there was a stronger positive effect in women who were screened. Low-dose CT scan showed more lung cancers, and the lung cancers that were detected were lower in stage. So there was a stage shift that led to a 5-year survival of 58% versus the previous 36%. When combining the 15 years of non-smoking with the low-dose CT scan screening, this led to a 38% reduction in lung cancer-specific mortality. Next, I will talk about the Nelson trial that was published in 2020 in the New England Journal of Medicine. It was the second largest trial after the NSLT. It was a Dutch-Belgian trial. It started in 2003 with a 10-year follow-up. They included around 800 persons in each arm. So unlike the NSLT, where the control group underwent annual chest X-rays, the control group and the Nelson trial did not undergo any testing. The screening group underwent low-dose CT scans in year 1, 2, 4, and 6.5. They included patients with the age range of 50 to 75 in the 7 districts of the Netherlands. Men and women in 14 districts in Belgium were sent a questionnaire about health, smoking, and cancer history. They include patients who were currently smokers, former smokers with 10 or less years of cessations, and patients who smoked for more than 15 cigarettes per day for more than 25 years or more than 10 cigarettes per day for more than 30 years. As we said, the control arm did not undergo any testing. The screening arm underwent 4 rounds of volume CT scans with PFTs and blood work at baseline. Quality of life questionnaires were filled up by the patients at each visit. And it's worth mentioning here that in the NSLT, the results of the CT scans were reported in centimeters, so the sizes of the nodules were reported. But in the Nelson trial, the volume of the nodules were reported, so there were volume CT scans, which in the study, they mentioned that it decreased the rate of false positives. The time interval between the scans were irregular, so there were 1, 2, and 2.5 years between the scans. The primary endpoint as well, it was the reduction in mortality from lung cancer with the screening, which reached 26.7%. Lung cancer was the cause of death in 17% of the patients who underwent screening and around 23% of the patients who did not undergo screening. So again, lung cancer caused more death in the control group compared to the screening group. The incidence of lung cancer was higher in the screening group, so it was around 500 cases per 100,000 persons per year, versus the control group, which was only 430 cases. Of the screen-detected lung cancers, around 70% were stage 1. In the control group, around 70% were stages 3 and 4. A sub-analysis of the Nelson trial again showed a stronger positive effect in women, but unfortunately, they enrolled only 16% of their population as women. The reduction in the overall mortality in the Nelson trial was much smaller than the NSLT. So in the Nelson trial, it was 3.2, while the NSLT, it was 6.7%. The quit rate for male smokers was 16.6%, which is higher than the population, which is 3 to 7%. The screening group was associated with a lower prolonged abstinence rate compared to the control group. They reported higher quit attempts if there were positive screening results. So in general, these studies have not shown an increase in the incidence of smoking cessation with screening. Now I'm going to review the most updated U.S. Preventative Services Task Force recommendation statement that was published in JAMA in 2021. To update their 2013 recommendation, the U.S. Preventative Services Task Force commissioned a systematic review on the accuracy of screening for lung cancer with low-dose CT scan and on the benefits and harms of screening for lung cancer, to provide information about the optimum age at which to begin and end screening, the optimum screening interval, and the relative benefits and harms of different screening strategies. In their statement, they recommended that adults aged from 50 to 80 years who have a 20-year past history of smoking and currently smokers or have quit within the past 15 years to undergo annual low-dose CT scan. The screening would stop if the patient quit more than 15 years ago, or they developed comorbidity that substantially limited their life expectancy or their ability to have curative lung surgery. This is a more detailed table with the recommendations for clinicians. Now we'll review the 2022 NCCN guidelines. And the NCCN guidelines, in my opinion, is a very valuable source for a lot of topics because they include the key trials of about the topics. And in the lung cancer, and if they don't have key trials for a specific topic, they include the consensus of a panel of experts in the field. In addition, for lung cancer screening, so they state the lung cancer screening guidelines. In addition to that, they include management plans for the CT scan findings based on the lung grad criteria. So it's worth mentioning that when the Nelson trial and the NSLT trials were conducted, at that time there was no existence of the Landgraf criteria, and that might explain the rate of it might explain why they had a high rate of false positives. Data have suggested that the use of Landgraf may decrease the false positive results in lung cancer screening. So the NCCN guidelines state that for patients with age 50 or more who have a 20 or more pack year history of smoking, that they should undergo low-dose annual CT scans. And on the left side, you can see a column of risk factors for smoking. So these factors are known to increase the risk factors, for lung cancer. So these factors are known to increase the risk of lung cancer, but unfortunately, they're not included in the guidelines because there were no solid data to show their association with or their effect on lung cancer. So they are used for counseling the patients. And as we know, counseling is a very important step in lung cancer screening or any screening program in general, because you're testing a patient for a disease that they might not have. The NCCN panel has not placed a time limit for screening eligibility after smoking cessation because the 15-year restriction is not based on or justified by evidence in their opinion. This is the Landgraf criteria for people who are not familiar with it. There are guidelines created by the American College of Radiology on how to report CT scan of the lungs done for screening purposes. So they categorize the nodules that are seen on screening based on 4 different categories based on how suspicious the lesions are. And the higher the suspicion for cancer, the higher level of nodules is reported. This is again continuation of the Landgraf's guidelines. So after reviewing the past, let's talk briefly about where we are now. So this is just a reminder that the number needed to screen to save one life from cancer, it's 2,000 for breast cancer and 1,200 for colon cancer. It's only 320 for lung cancer based on the NLST trial and 130 based on the Nelson trial. So there are some data from Saudi Arabia that anticipate an increase in the economic burden on the country because of the cancers in the near future, including lung cancer. Having said that, there is no national screening program for lung cancer in the country. There are some Riyadh-based single institution initiatives like the Al Faisal University Initiative, and I congratulate them for taking this huge step. This is the roadmap, which looks very promising. They include the King Faisal Hospital and I think 4 or 5 other hospitals. Dr. Khalid Gattan can kindly let us know more about it after the presentation. So where should we be heading with this information about the past and the future? In my opinion, this is the most important part of the presentation. So, of course, the goal is to start implementing a national lung cancer screening program. And this will start with basic steps. The most important basic step is mass awareness to the public and the physicians as well. So this can be accomplished by campaigns, webinars like that, or even brochures. After mass awareness, a multidisciplinary approach is paramount in this step as well, including primary care physicians, radiologists, pulmonologists, oncologists, and thoracic surgeons. And the main final goal would be hopefully to get the support and involvement of the Ministry of Health to officially implement this program across the country. We should consider testing a few points in the process as well, like testing the trend of lung cancer in Saudi Arabia in general, testing the trend of lung cancer based on age and gender, the trend of smoking in men versus women, and the trend of healthcare improvements and the changes that have been happening recently. We will face some challenges for sure in our way, like knowing the true incidence of lung cancer in the country, the high incidence of inflammatory or infectious nodules like TB, and how high this incidence is in our community. Unfortunately, we don't have solid epidemiological data regarding lung cancer and the numbers of lung cancer in the country. The availability of low-dose CT scans and trained radiologists to read the results would also be a challenge. What are some important questions that we should answer before starting such a huge program? So should we apply the international criteria for lung cancer screening, or should we develop evidence-based criteria of our own? Will it be cost-effective, considering the high incidence of benign nodules in the community? Are we different in terms of lung cancer incidence? There are some statistical data that stated that the incidence of lung cancer in Saudi Arabia is lower than other countries, but I would take that with a grain of salt, especially that we don't have solid epidemiological data and we don't have screening programs, so a lot of patients go underdiagnosed and die with the disease instead of being diagnosed with it. I cannot talk about lung cancer screening without talking about quitting smoking and smoking cessation. Important part of screening is to counsel the patient for smoking cessations, and creating programs to help the patient quit smoking is very paramount in this process as well. These are my references. Thank you for listening to me, and I welcome any comments or questions.
Thank you so much, Dr. Soha, for this very nice and concise review about fundamentals and rationales of lung cancer screening. And hopefully we'll see you soon with your group and with the rest of our group in Saudi to lead up a lung cancer screening program in Saudi Arabia and hopefully in the whole Middle East. I apologize, but I forgot to mention, if you have any questions or comments, please type it in the comments box for the question and answer. And then we will review it once with suitable time. But thank you. And then with our next moderator, Dr. Walid Saleh.
Assalamu alaikum. Thank you, Dr. Soha, for this excellent presentation. I'm Dr. Walid Saleh. I'm consultant thoracic surgery at King Faisal Specialist Hospital. It's my great pleasure to introduce Dr. Ahmed Bamousa. Dr. Ahmed Bamousa is a well-known senior thoracic surgeon. Did his training in Toronto General. Then he came back and joined Prince Sultan Medical City. Since that time, he's practicing thoracic surgery, doing complex cases, active in all the meetings. Without further delay, my pleasure to invite Dr. Ahmed Bamousa to start his talk about the surgical management of early lung cancer. Please, Ahmed.
Thank you very much. My voice is clear, am I right?
Yes,
Yes.
I can hear.
Can you hear me?
Yes.
Okay, so I have nothing to disclose, and lack of time, so I have to go quickly. This is my the things that I'm going to cover in my talk. As you all know, surgical resection of lung cancer is still regarded the most effective method of controlling the primary tumor. In Saudi Arabia, a report came from Al Faisal University shows that from 1999 to 2015, we almost have double case of new cases, 564. And we expected in 2030 that we reach almost like 1,000 plus new cases. And that's actually give a burden in our economy. Believe it or not, in 2015, it had been estimated that the cost burden is almost like 2.49 billion US dollars, almost like 21%, which equal like 521 million just for the care, and the rest for the loss of the productivity. And if you look to the 2030, we are going to reach almost like 50.6 billion US dollars. I love this slide and every presentation I presented, and it's actually educated for everybody. If you see a patient with a lung nodule like this, you have to ask yourself, what is this? Am I dealing with cancer? Look for an old X-ray. If it is there, then most likely, if not, but if an X-ray 6 months back, this was not there, then probably you are dealing with cancer, especially in patients who is smokers. You have to get a tissue diagnosis by either transbronchial biopsy or CT scan guided biopsy. Once you know that that's cancer, then you do the staging. Now the recommendation, the American Association recommendation of surgery, that you have to do PET to look for rest of the body, and then you will discuss what's the best options treatment, and then you will see if your patient is suitable for that treatment. I'm not going to talk in details about the TNM staging, because actually this, at the end of this year or beginning of the next year, the 8th edition is going to be changed, but I have to speak a bit mediastinal staging. So if you have a negative PET CT with a peripheral lesion that is less than 2 centimeters and it's adenocarcinoma, then probably you will go directly with surgery. But if you have central tumor more than 3 centimeters, then you have to do your workup in the mediastinum in the form of EBUS or EUS or video-assisted mediastinoscopy, prove it is negative and go for surgery. Otherwise, you go for multimodality therapy and then confirm if it is negative and then go for surgery. Now, in Yang, in 2015, have introduced a new concept, which is the circulating DNA. And actually, he stated that this can be screened for early detection of cancer. Even it can help in the target therapy, and it can help to see if your surgery performance after the surgery, if it is negative, then probably you have cured. And in fact, he actually added this in the TNM classification, and he assumed that this will be the TNMB, B0 with no circulating DNA, and B1 with the circulating DNA. Now, what's the role of surgery? It can be diagnostic or therapeutic. The diagnostic in the form of cervical mediastinoscopy, which is basically a skin incision about 1 finger breadth above the suprasternal notch, where you put the mediastinoscope, either video assisted, and then biopsy the lymph node. Now, the surgical principle of surgery is that the tumor on all accessible mediastinal lymph node should be removed completely. You should have in-block resection of the closely adjacent or embedded structure, avoid tumor spillage during surgery, and assess the resection margin by frozen section. And if there is a positive resection margin, should be resected whenever is possible. The International Association of Lung Surgery came in 2020 with the new definitions of complete resection, incomplete resection. And this actually has to be consideration when you do the surgery. The complete resection means that you have a free resection margin microscopically in the bronchial, vascular, and others. you should have a systemic nodal dissection. And I mean by systemic nodal dissection, according to the site of the tumor, you should include 3 mediastinal staging, including the subcarinal, as well as 3 intrapulmonary stations, a total of 6. There should be no extracapsular involvement of the lymph node, which removed separately, and the highest mediastinal lymph node must be negative. On the other hand, incomplete resection means that you have a positive resection margin, the extracapsular nodal involvement removed separately, the non-positive node have not been removed during surgery, or you have a positive cytology either in the pleura or the precardial effusion. Uncertain resection means a resection margin free of the disease microscopically. Intraoperative nodal evaluation did not meet the criteria. The highest mediastinal lymph node is positive. The bronchial margin has a carcinoma in situ and positive pleural cytology. The standard of resection for nodules have been changed dramatically from all over the place. Recently, in 2005, we have been the introduction of video-assisted thoracoscopic lobectomy, and until 2010, the robotic-assisted thoracoscopic surgery. This is the famous open posterolateral thoracotomy with painful outcome, long time for recovery, replaced by video-assisted thoracoscopy with a 3-hole surgery. You could do wedge, you could do segment, you could do a lobectomy, or you could do pneumonectomy. This is the famous trial of Bob Ginsberg, published in 1995, stating that lobectomy is better than limited resection in the form of recurrence and survival. We, since that time, continue to do lobectomies, and recently in 2017, that Dr. Turki, Nasrat Turki from United States, present this in the meeting in Barcelona about the peripheral mortality and morbidity and the outcome of subglobal resection in compare for lobectomy in early stage. We're still waiting for the result, but recently in April 2022, this paper came about Jacob 80 comparing segmentectomy versus lobectomy in a small size peripheral non-small cell lung cancer phase 3 randomized controlled trial. It shows clearly that the segmentectomy is superior than lobectomy. However, the progression-free survival rate did not show any difference between both groups. Not only that, the recurrence rate was higher in the arm of segmentectomy, local recurrence 10.5 in compared to 5.4. In the surgical margin, the segmentectomy group have positive 11 patients in compared to 0 patients in the lobectomy. In this study, they also studied the lung function test, and they came strangely that it's only a reduction of 3.5% in the forced expiratory volume in the segmentectomy group in compared to the lobectomy. Now, why is that? There are, I believe, 3 causes for that. One of them is the learning curve. In 2018, segmentectomy, you have to do an 84 cases in order to master segmentectomy, while lobectomy 50. The other thing new is actually the STAT, which is the spread of the tumor through the airway. This is a study have been published in 2015, and it shows that in patients with positive tumor spread, cases which have been done by segmentectomy, which is stage 1, there is a high chance of local as well as distant metastasis in compared to the lobectomy group. The third probable cause for that is another study done in Britain, where actually it's a retrospective study. They actually look for the margins, and they divide the margins between less than 1 to 1.5 and 2 centimeters. And they found that the higher the margins, the free margins of the tumor, the higher the incidence that you don't have. Now, this is basically the treatment strategy of the tumors of lung, non-small cell lung cancer. Early is actually treated by resection. Once you're at stage 2, probably you will give an adjuvant therapy. The same for this group of patients. And now the question is what we will do with the N2 diseases. Believe it or not, in a paper published in 20 2020 from the National Lung Cancer Society in Britain, you could see that there is a heterogeneity in the treatment of this group. Some of the patients were treated with basic life support. Some of them were treated with surgery and radiotherapy. And the reason for that is that into disease is heterogeneous. It's either from change from occult into disease to all the way to mediastinal infiltrate. And that will make a difference in the type of treatment. All of this depends upon the tumor burden as well as the performance of the patient. So what are the definition of resectable into disease? The best one is actually coming from the British Society, non-fixed lymph node, non-bulky, single station into disease with a reasonable chance clear margin. The NCC guideline just mentioned that it's single station. So as a surgeon, the criteria is actually that you have to confirm the diagnosis, you have to work up the patient with mediastinal staging. Once you know that the nodal disease is discrete, easy measurable, less than 3 centimeters, not encasing mediastinal structure, away from the tumor, you could achieve a lobectomy, not a meninectomy or other resection, with an R0 resection, and the patient should tolerate whatever you are going to give the patient post-op treatment. There is a guideline. All the guidelines support the treatment. Now, there is a role of radiotherapy in the resectable into disease. All of the studies before 2022, they were not randomized. Till we have the lung ARC study, which is an open randomized phase 3 trial looking for resected into disease, and they conclude that there is no role of radiotherapy as in the treatment of resectable. And the only role for radiotherapy is actually the superior sulcus tumor with no involvement of the mediastinal lymph node. The reason why? Because the radiotherapy will not increase the survival of the patient, and it will increase the toxicity of the cardiac toxicity post-exposure. The tumor genome have been growing very tremendously in the last couple of years. The tumor, including circulating DNA, is actually important for us as a thoracic surgery to understand and adapt in our practice. Next one is the ADORA study, which is actually a phase 3, a double-blind randomized study, including all patients resected with positive EGFR. And believe it or not, they include early stage 1B to all the way to 3A. Those patients have been randomized to be given isometrip or placebo and looking for the disease-free survival. They actually published this in the New England Journal in 2020, which shows clearly that if you resect patients with positive EGFR, and give them a chemotherapy plus or minus isometrip, actually you increase the survival of those patients up to 83%. You decrease the chance of recurrence, and you decrease the chance of death from the disease, as well as you decrease the chance of CNS metastasis. And this actually have been approved by the FDA to be there. And actually, in the new guideline 2002, it has been now mentioned that patient with positive EGFR isometrip is an excellent treatment to be given. Now, the challenging with the TKIs is that if they are cytostatic, not cytocidal, they may actually decrease the chance or suppress the invisible asymptomatic disease. Their major pathological response, as well as the pathological complete response, is not that much. And here we are talking about the disease-free survival for the first time. We are not talking about the overall survival. And in the study, they were putting the patient on 3 years treatment, but none of the patients continued for 3 years. It's actually 22 months. And there are also side effects from such therapy. And of course, we don't know what's going on with other treatments. Now, there are a leader trial which is going now in multicentric centers in states where they are looking for all of this. They are actually looking for patients to be given as a neoadjuvant therapy, followed by the surgery, and they are trying to recruit 100 patients, and we will see the result in the future. The challenging with the neoadjuvant TKI, the preoperative testing for targeted economic drive is not uniformly found, and it's only tissue acquisition and processing are major drive back for the genomic testing. Unfortunately, surgeons remain slow adapters for the concept of the neoadjuvant therapy. Clinical trials are currently limited, and there is a real benefit of 8 weeks neoadjuvant therapy when most of those eligible patients will receive adjuvant TKI therapy. What about the role of neoadjuvant immunotherapy in patients in early stage lung cancer? There is a lot of ongoing trial looking for this. And the first one which have been published is actually the CheckMate 816 trial, which is for the first time, it shows that there is a complete pathological response. And in fact, the company, this was actually presented in ASCO last year, 2021, and the company stated that they don't need to continue the trial as they have reached the efficacy of endpoint. So if you give a pre-op chemo immunotherapy, this will improve the free-disease survival in those patients from stage 1B up to stage 3A. Basically, this is the trial study, the design. All resectable patients have been divided into patients receiving nivolumab chemotherapy, followed by chemotherapy with reassessment radiologically, and then staging and then do surgery after 6 weeks, and then you give the patient adjuvant treatment post-op. You could see that the pathological complete response was high even in early stage of the disease. Did that affect our surgery? No. There were no delay in surgery. There were more cases was done video-assisted thoracoscopy. There were no difference in the length of the stay in the hospital, and there is no difference in the 90 days complication rate. What about the Empower 110, where patients who are positive with the PDL1 more than 1%, if you give them atezolizumab versus platinum-based chemotherapy, you actually increase and improve their survival. The median overall survival is 20 months in compared to 30 months if you give them only platinum adjuvant therapy. And now this has been approved by the FDA. And actually it was presented in 2020 as a first-line treatment of BDL selected non-small cell lung cancer. Even further, it was actually presented in 2020 guideline, where you have even that you have to give the patient either atezolizumab for the BDL1 or omegetrip for patients who have Now, neoadjuvant therapy
2 minutes, Ahmed.
Have opened a new horizon. See, all of this, they are all included. This is phase 2 trials, and they are all have a very good major pathological response. And now there is a lot of study going on, and we are waiting for all of the results to see all of the patients. This is the new actually phase 2 trial where we are using nivolumab with even target therapy for the patient. I'm not going to discuss this because now, in summary, and this actually the consensus which came with the American Association of Thoracic Surgery in May 2022, that intraoperative lymphadenectomy should include 3 mediastinal lymph node and 3 hilar intrapulmonary stations. Lobectomy remains the standard procedure up to date, but segmentectomy is acceptable in selected patients, meaning patients who cannot go for a lobectomy, patients who have a peripheral tumor with no evidence of radiological mediastinal disease, or patients who have multiple lymph nodes. Early molecular testing, BDL staining, should be addressed early in the treatment because that will help in the pre- and post-operative treatment. Resectable clinical into disease should be treated with neoadjuvant therapy followed by surgery with no role of the radiotherapy. Neoadjuvant chemotherapy is reserved, and neoadjuvant chemoradiotherapy is reserved for patients with serous tumor with no into disease. All resected stage 2, 3 squamous cell carcinoma should undergo BDL testing. All patients with stage 1 to stage 3 lung adenocarcinoma with EGFR mutation should be discussed for the adjuvant osimertrep. All patients with the early stage disease with BDL should be considered for atezolizumab. Thoracic surgeon, as we know our patient better and we know when should we do the surgery, we should be leading the tumor board, and we should address whether this patient receive what type of treatment and if we can do surgery for him to achieve complete cure. Thank you very much.
Thank you very much, Ahmed, for this overwhelming presentation for treatment of surgical treatment for early stage lung cancer. I don't see any lots of questions. There are questions also for Dr. Soha. I don't know if Ashraf, if you want to address this or later on.
We can go over it, Walid, at the end of the fourth session.
Yeah, sure. And thank you very much. We'll have a short break, or we just proceed to the
We'll have a break for 5 minutes, and then we'll come back.
Okay, thank you.
الو هلا وسهلا ما حدش قال لي wait 5 minutes.
Welcome, Prof.
So welcome back, everyone. We'll start the third session. Now, the third session will be moderated by Professor Khalid Al-Qattan. He's a professor of surgery and Dean of College of Medicine at Faisal University and consultant of thoracic surgery at King Faisal Specialized Hospital Research Center. So please, Dr. Khalid, go ahead.
Yeah, thank you very much for your kind invitation. I'm already enjoying the first two sessions and the two brilliant talks. I think we started gradually. We started with screening of lung cancer, then we moved to early stage lung cancer, and now we want to extend this to the stage 3 lung cancer. This is a topic that it is great that it will be presented by Dr. Saleh Awdaf. Dr. Saleh is a consultant thoracic surgeon at King Fahd Medical City. I've known him for a long time. He is a bright surgeon, leader in minimally invasive, and I'm sure you will enjoy his talk about the role of surgery in stage 3 lung cancer. So please, Dr. Saleh, the floor is yours.
Thank you very much, Professor, for the kind invitation, and thank you, Dr. Saleh Nasser, Dr. Ashrafi, for involving me in this talk. I have the unenviable position of giving a talk on something that is hotly debated and with a lot of conflicting data. Also, I'm at a disadvantage because Dr. Bamusa has mentioned a lot of the some of the points in stage 3 lung cancer, but I will do my best to give the listeners and the attendees as much information in this brief amount of time. To be clear about this talk, there are no conflict of interest, but this talk is specific to non-small cell lung cancer. It is not including small cell, and it's not including neuroendocrine cancer, and specifically does not include Pancoast or superior sulcus tumors, because that has a different rationale of management and different evidence. We're going to look at the 8th edition changes. What are the variables that are involved in stage 3, and look at different scenarios and surgical challenges and the evidence that support it, particularly for N2 disease. And I'll try to give you a brief summary of where we are today and where we might be going in the future. This is stage 3 lung cancer, and if you look at, this is the staging system, for lung cancer. And if you look at stage 3 from A to B to C, it is the widest and most variable stage. It includes a lot of heterogeneous diseases that probably shouldn't belong together, but are grouped together. If you look at the stage 3 on its own, again, A, B, and C, it includes a lot of small tumors with advanced N2 lymph nodes, or a lot of early large tumors. These could also be multivariable or invasive, or N3 disease cases, but all of them do not include metastasis. Metastasis automatically takes you to a stage 4. The issue with stage 3 is it has an immediate dropout in survival. If you look at the survival for stage per stage, there's a sharp 20% drop between 2B and 3A. It is the sharpest and suddenest drop in mortality in the staging system, and that's because of the heterogeneity of the diseases. But if you look at the variables independently, the T variable has 3 descriptors. The first descriptor being size, the second descriptor being multifocality, and the last descriptor being invasion. These are 3 very different things. the IASLC had a really good data set of about 100,000 patients, and that data set had been validated for most of the stages for most of the variables. So what that means is we know that for each centimeter, mortality increases. And we know that the cutoff is technically 7.3 centimeters, but it has been crossed to about 7 centimeters just for simplicity's sake. That's all been validated. There are some variables that haven't been validated, and those are mainly invasion variables. So the changes that you see come from large data sets. There's an up staging of T4 for larger than 7 centimeter, down staging to T2. This used to be T3 in the old system. Diaphragm has gone up to T4, and this is mainly related to the systemic blood supply and the rich blood supply of the diaphragm. The other thing that the staging system has answered, it has specified for us scenarios of multifocality. So if you see multiple nodules or multiple lesions on the CT chest, it behooves the oncology team and the surgical team to check on what kind of scenario that is. Is it multiple cancers? Is it multiple GGOs? Is it a mnemonic type? But for this talk, we're going to be talking about separate nodules of the same cancer, and specifically multifocality T3 and multifocality T4, but not M1A. The other scenarios are not the scenario that we're talking about today. The 8th edition didn't change anything about the N2 mapping. The overall mapping hasn't changed. There is a note on the ISLC about the number of lymph nodes, whether N1 or N2, and whether they skip or they don't skip N1 stage. There is some data to suggest that multiple lymph nodes do worse. In fact, there is quite a strong amount of data that suggests multiple N1s perform worse than single station N2s. And this has been going on for more than 20 years. And since Naruke described his map, there's data that spreads back to the beginning of the lung cancer staging system. But probably in the next edition, we're going to see a real answer about how are we going to look at these lymph nodes and how are we going to sample them. Dr. Ahmed had a really wonderful slide about the definition of bulky. We use the word bulky, and there's no fixed standardized definition across the globe. The BTS has a good one, but for this talk, bulky means fixed, non-resectable, usually with extracapsular extension and usually in multiple amalgamated form. Now, when you go to the tumor board, your colleagues will look at these tumors, and sometimes they'll say, oh, look, it's localized. You can draw a circle around it. That means you should be able to take it out. Well, if you can take it out and whether you should take it out are two different questions. And this has to do with the patient's physiology, the operability of the patient, and the staging and anatomical considerations, which is resectability. And these are, again, two very different things. Staging is different from resectability. So most of the stage 3 lung cancer that come into my tumor board, I check everything again and again. I usually ask for more advanced physiological assessment. I'll take a deeper look at PPOs, which is the predictive postoperative lung function, particularly if I'm planning to do a bilobectomy or a pneumonectomy, or I'm removing a chest wall or diaphragm with my lung cancer. If I have an EBUS or I have a PET scan where it looks negative, that's not enough for this case because the survival is two-thirds of them don't survive anyway. So you have to check to make sure that lymph node is or isn't involved. And sometimes that works in the favor of the patient, but most of the times they're upstaged. And I'm going to show you an example of that in the slides. But ultimately, when you get a stage 3, you're looking at two different challenges, the T challenge and the N challenge. And there's clear recommendations for the T challenges. The N is a little bit more complicated. So if your T status is T3 for size or multifocality or invasion, or T4 due to size, multifocality, or invasion, the recommendations are straightforward. If you have only N1, T3, that's a stage 3A. And if it's due to size or multifocality, you should undergo your planned resection. So if it's a lobectomy, do a lobectomy. If it's central and you need to do a pneumonectomy, do a pneumonectomy, provided your patient can tolerate it. If you're T3 N1 due to invasion, you need to achieve R0 resection. This could be challenging in elderly patients where you have to remove multiple ribs or the entire sternum, because that's usually what a T3 invasion. But if you can provide an R0 resection and provide an adequate reconstruction and coverage for your resection margin, then yes, you should go ahead and plan and do this operation. For T4 multifocality, if you have tested it and you've done genetic testing and you know it's the primary tumor or the same tumor, you should go ahead with your planned operation. And this could take the form of a lobectomy, a bilobectomy, a pneumonectomy, a lobectomy plus wedge, a lobectomy plus segment, or if your patient cannot tolerate a large resection, you should take the large bulk of tumor out through a lobectomy. And if it's a small nodule in the other lobe, then you could consider giving radiation and radioablation. That is acceptable treatment option in very extreme cases. What about size? Size hasn't really changed the attitude of the surgeon. We've always been resecting tumors larger than 7 centimeters. I've learned around 10 centimeters. I've learned to extend my Alexis port for minimal invasion. So I pretty much think that really large tumors, you're going to open one way or the other. Whether you're doing Alexis plus rib shingling or you're putting in a retractor, it's unlikely you're going to be able to get that tumor out in a bag through a 3 centimeter Alexis port. It's just not possible. But for T4 invasion, we know that surgeons are quite good in resecting the diaphragm. There are exceptions in cases that involve the IVC or hepatic veins. That might not be operable, but most of these cases are straightforward and operable, and those should be done. The cases that are unvalidated are cases like the carina, the mediastinal vessels, and the vertebra. Most of these cases are considered inoperable. Now, you might tell me there are Ginsburg cases, there are Darteveld cases that have done aorta or superior vena cava. Sure, absolutely, but those are extremely selective cases. We don't know if it's a good idea to resect them. But the general recommendation at this point is not to resect them because the surgical risk is so high and the benefit is questionable. This is an example of that. This is a right upper lobe invading the vertebra. And so you can see here 2 thoracotomy incisions. This is a thoracotomy at the 5th intercostal space for the hilar control. The lobectomy has already been done. And this is the counter incision at the 3rd rib. So 4th, 3rd, and 2nd ribs have been removed and blocked with the spine. And the spinal surgeon has put fixation rods or fixation pins for the rod. So that is technically can be done. It's just not always recommended because we don't have validating data for it. So it's a difficult, debilitating operation with a questionable benefit, but you can consider it in extremely limited cases. In terms of N2, N2s are not created equal. There are different types of N2s. The role of pneumonectomy in N2 is a big issue. Should you give neoadjuvant chemo or chemorad in N2? And how would you restage after neoadjuvant? And what about N3? These are all questions regarding the N challenge for the surgeon to address. The N2 are not created equal. There's a ACCP criteria or the Robinson criteria of N2. And for this talk, we're looking at N2 that is recognized preoperatively. So we're looking at the N2-3 subset of the ACCP classification. If you have an N2 post-resection, those usually behave quite well. If you find it only on microscopic on the frozen section, you should go ahead and do your operation. But if you see it before you go in, you've tested it and it's positive before you go in, what should you do at that point? The N2-4 subset are the unresectable ones, the ones that we have termed bulky. So these ones, the single station usually potentially resectable. There's a lot of conflicting randomized controlled trials looking at neoadjuvant therapy. They started the Barcelona trial, which is about 60 patients that they looked at surgery versus chemotherapy plus surgery. Now they found that there was a significant survival advantage, but the 5-year survival wasn't good. The reason for that a lot of these cases had T4 and N3 disease. MD Anderson did the same sort of study in the same period with the same number. The chemotherapy regime was a little bit different, but they didn't include any N3 cases. These patients had a much, much better 5-year survival. So there's a lesson there. The intergroup study is a very famous study. It's a study that's quoted by all my radiation oncology colleagues. It's a study that looks at chemotherapy plus radiation, and then you continue to either just surgery or just radiation. And they found that radiation was equal to surgery in the outcome. And so the outlook for the radiation oncologist is that radiation is just as good as surgery. But this is not true. The reason that they came out equal is because if you did pneumonectomies in these cases, and there's quite a bit of them, there was a higher surgical mortality rate. However, if you removed the cases that died from the pneumonectomy and you took out the ones that had surgery and went home, those patients had a significant survival benefit. So the subset analysis is great, but the number is so small. So there's 2 ways of looking at the study, and I look at it at the surgical way. There is a benefit there, but you have to make sure that your patient survives, and it's not a pneumonectomy because most of those are the ones that die. Now, what about the EORTC trial? This is another very famous European trial that found similar results, and they looked at giving chemotherapy followed by surgery or radiotherapy. But a lot of these cases were open and close surgeries, or open with positive margin. 40% of the cases had to have radiation afterwards because of positive margins. These were very advanced cancer. So the idea here is you need R0. The Spanish trial, this is the one that closed in 2015. And again, they looked at chemotherapy and radiation and whether to do surgery or not. Survival was again equal, but that was because they closed early. They couldn't reach the number that they needed to reach. These trials are expensive. So these are the lessons from these trials. There are multiple other small trials that showed the same thing. It's not easy to show a benefit. We believe there's a benefit. The subset analysis shows a benefit, but it's a difficult study to do. It's a long study to do. It's an extremely expensive study to do. And it requires a large number of patients, so it takes a lot of time. So that's the problem with these studies. But what are the lessons we know from these studies? We know that it has to be an R0. The lymph nodes have to be removed. Patients who respond to chemotherapy, they do better. There's a slide here that I removed due to time, but basically you have a large number of patients, about a third, do not show up to the OR after neoadjuvant because the disease progresses. So the patients that don't progress, they do quite well. So the neoadjuvant is like a litmus test to the aggressiveness of the disease. It gives you time to treat and see how they respond. And of course, if you're going to do a surgery, try not to do a pneumonectomy. Do we need radiation as a neoadjuvant? Well, there's a trial for that, and it closed in 2014 and been repeated with the PORT trial and showed no added real benefit. But there are still people who do it. There's quite a lot of large centers in the Eastern United States, North America, and many centers in Europe that add chemoradiation as a regime. The problem with chemoradiation is there's no difference in survival. There's a real concern about surgical complexity and complication rate. There's a more cost and logistical burden for the patient. And the most common regime worldwide in terms of number is chemotherapy only. So my feeling is generally that you're going to see radiation die off. And that goes a lot with what Dr. Ahmed Bamoussa was saying. N2 in pneumonectomy is one of the hotly debated topics. Ginsburg and Rush presented a paper many, many years ago when Valerie Rush was still quite young. She's a retired surgeon by now, but she was quite young at that time. And they were against pneumonectomy in N2 disease. But in 2010, Walter Vader from Switzerland showed that you could get good outcomes if it's a single station and it's resectable, even an extended pneumonectomy. Later on, Valerie Rush in 2013 presented to the AATS the data from the Mayo Clinic, and they showed that in the Mayo Clinic, there are a subset of patients that improve and have survival. But again, these are all selective. It's not all comers. These are selected cases. Should you restage after neoadjuvant? I don't think anyone has really asked the question well. This is a very small study that looked at different response rates. We know that the positive rate in surgery is higher than the CT, than the PET. But I think everybody agrees that you probably should repeat the PET. However, there are certain centers that do not restage, okay? So that's still one of the topics. What is the best way to restage? What is the access? Should it be surgical? What is the plan afterwards? If you're considering to do surgery for stage 3 due to N2 disease that is identified preoperatively, again, we're going to repeat the points. You should consider a single station that is resectable. You should consider giving chemotherapy and that they should respond or improve on chemotherapy. You should restage with at least a CT or a CT PET and try to do, if possible, a limited resection, not a pneumonectomy or extended pneumonectomy. For stage 3B diseases, we don't actually have data for 3B diseases directly. The EORTC and intergroup trial did not include 3B. The SPATU trial had a large number of 3B cases, and they didn't show any improvement. So the general feeling is that there's no improvement there. There are some blind scenarios where studies can't really pick up. If you find occult cases of T3, T4, and N2, you probably should take them out. If you find N3 disease that disappears after neoadjuvant, some people will take those out. But again, not a lot of strong evidence for that. There's no role to support overt large tumors and N3 disease so far. If you're considering doing these cases, it really should be part of a trial. It's experimental. The tumor board needs to understand that. The ethics committee needs to be behind it, and the patient needs to be completely aware about it. There's no survival benefit as far as we could tell. The survival rate is quite low for these people. Now, if my talk has confused you on what is the recommendation for lymph nodes, don't be discouraged. There is no consistency in the world regarding this issue. This is a map of what to do in stage 3 due to N2 disease. Is it resectable or not? Is it multiple or single? Is it bulky or not? And it looks at all the major international organizations, the NCCN, the ACCP, the Australian, the German, the Spanish, the European Society, the Chinese, the British Thoracic Society, the British National Institute of Excellence in Healthcare, and as well as the Irish Society. They're all over the place. Generally, ACCP and NCCN is generally what we follow. But you should know that around the world, what is being done is different. And even in the UK, from one hospital to the other, it's different. This is sort of a color map of what to do. If you're in zone green, green means go. If you're in zone red, red means don't touch. And if you're in zone gray, you really need to talk to your oncology team, and you really need to talk to your patient, and you really need to check everything twice. This is a summary of the talk. I'm not going to go through it. The reason is I was part of a wonderful group, which is the Saudi Lung Cancer Association. Part of the Saudi Thoracic group includes some wonderful people. I'm sure you all know Dr. Jazia, Dr. Zaytouni, Dr. Lutfi, Dr. Lahabi, of course, Professor Qattan. And we published the national guidelines. So these are the Saudi guidelines for stage 3 non-small cell lung cancer. You can find them online. You can find it in the King Abdulaziz library. This is an example of something like advanced. Like this is a case quite recent. This is a patient that has a T4 tumor to size, potentially T3 to invasion, and hot on PET. Let me stop that here. Hot on PET on the periaortic lymph nodes. PET is hot at the N2 stations. So these are lymph nodes you cannot EBUS, you cannot do mediastinoscopy for. So what we did is we utilized VATS and we dissected the entire area. So that allowed us to sample stations 4, 5, 6, 7, 9, 10, and 11, and also sample the chest wall to clear it off the pleura. And once we found all of that is negative, then we extended our incision and performed the lobectomy. So that is a very powerful tool. This was radiologically T4N2 disease. It went down to T4N0. So that's one of the examples of how you can utilize surgery in the management of these cases. Where is the future going? I think Dr. Ahmed Boussa presented it better than I could ever do it. Sublobar resections is coming in a very strong way, both in terms of wedge and segmentectomies. The number of lymph nodes and probably the location of the lymph node is going to be looked at some time very soon. Multiple trials for targeted therapy as neoadjuvant therapy. You are not going to see any more trials of neoadjuvant chemo. You're going to see only neoadjuvant targeted therapy because these are mainly sponsored by large corporations, and they're looking at it as a very expensive investment. One of the more recent ones that just published their one-year analysis is the phase 2 Swiss trial, the SAC 1614 trial. There's a 1600 before this, which looked at safety and efficacy, but this is looking at it as a neoadjuvant for N2. The follow-up is still short. It's only 1 year. It's still a phase 2 trial, but this is probably one of the ways of the future. You're going to target for the genetic drivers, and then you're going to give them therapy for those genetic drivers instead of chemotherapy or radiation, and then they'll come up to surgery. So that's quite exciting. I think I'll stop my talk here. Thank you very much for listening.
Thank you very much, Dr. Saleh. Wonderful talk. We leave difficult cases to a bright surgeon. I think very well explained. Thank you very much. And we move to the next session.
So now we'll move to the fourth session about the role of immunotherapy and target therapy in lung cancer. That will be presented by Professor Khalid Saleh. He's a professor of medicine at King Saud University and consultant of oncology at King Saud University Medical City. So, Prof. Khalid Saleh, floor is yours now.
Assalamu alaikum and good evening, everyone. And thanks for the kind invitation. My only disclosure that I'm a medical oncologist coming after three excellent thoracic surgeons. So my talk will be hard, actually, but I'm glad to be here. And actually, I love my thoracic surgeon colleagues, so I have nothing against you guys. Anyways, now it's really difficult to cover immunotherapy in lung cancer over in the next 20 minutes. That's actually next to impossible. This was a revolution on the science. And to prove it to you, this is actually what made people win a Nobel Prize in 2018. And more important, actually, King Faisal Prize, as you can see, it has been won on the same year. So King Faisal actually gave them the nomination about 8 months prior to their winning Nobel Prize in medicine. And this is for the discovery for PD-L1 and CTLA-4 antibody. And this was a huge revolution. I still remember the first presentation coming in ASCO, and everyone was dropping their jaw to see a lung cancer survival stage 4, 15%, 5 and 6 years outwards, which was unheard of. And that's why you're going to keep hearing this. And we are still learning where we're going to be able to use our immunotherapy in lung cancer, in surgical with the radiation therapy and all that. Now, there was an excellent talks about using immunotherapy in limited or non-metastatic setting, and I'm not going to be covering this again, but I'll be trying to cover mostly the metastatic setting and looking for certain things. And we're going to be focusing on the BDL1 expression level and the overall survival with that. Now, I have only one slide for stage 3, and probably that's going to be relevant. Just to show you actually what we were thinking before the immunotherapy and after immunotherapy. So in stage 3, we used to say we're going to do radiation therapy, concurrent chemoradiation, sequential, and some of the trials has been done. And even though it did show some benefits, and so we can look to the first trial on the left, which is showing radiation therapy versus sequential radiation and chemotherapy. And you can see actually the hazard ratio was 0.08 with a significant p-value, and they have tried to recruit 800 in each arm. And you can see the difference is minimum, and you're going to be able to see it at the end of the tail of the curve. Now, when people say sequential versus concurrent was better with the hazard ratio, significant p-value, and you can see the significance was mostly after 36. After you live 3 years, yes, you're going to see the benefits, about 5%. When immunotherapy came in a Pacific trial, first time now to see when we see 2-to-1 randomization, not 1-to-1 randomization, and you're going to be able now to see a median survival difference, anything from 47 months, from 29 months to 47 months. This is how powerful you're going to do this. And to be in a more plain way to put it down, we always said stage 3 is a heterogeneous disease. N1, N2 disease is heterogeneous. We're probably missing some occult metastasis. Probably the surgery was not enough. Now, probably we're going to be able to overcome that if you do a very good, reasonable surgery and then give immunotherapy, because probably those micrometastases is going to be dealt with the immunotherapy. So that's why immunotherapy is really coming as a big tool across the board for metastatic and non-metastatic setting. Now, that says enough about the metastatic, non-metastatic stage 3 non-small cell. Now we're going to move on to focus on stage 4 metastatic. Now, it's going to be important to keep in mind that this is a targeted therapy. This does target a BDL1 expression, even though it doesn't predict the response 100%, but definitely this is one of the markers for response. Now, there's a lot of trials talking about the role for immunotherapy in non-small cell lung cancer. Now, but we're going to be focusing on the main agents, Pembro and nivolumab. Now, obviously, they were fighting by teeth to take their position. And they did a lot of study, which is just jumped from phase 1 to a phase 3 randomized in a very massive way in no time. And we should remember, phase 3 are very expensive, but people continue to do that because the one who's going to be taking the role going to be controlling the market. And actually, that's exactly what happened with Pembro. So Keynote 024 was the first-line pembrolizumab in advanced non-small cell lung cancer, and their inclusion criteria was chemotherapy naive with a stage 4 non-small cell, and you have an expression more than 50%. And they use a specific score called the TPS. Now, obviously, there's no driver's mutation, and there is no untreated CNS metastasis. And they have been randomized to a platinum doublet, quad standard therapy, and to a pembrolizumab. And look how small is the sample size, 154. And the result was quite impressive. Now, in those population, we are not using any chemotherapy. If you have a high expression of PD-L1, we just give you immunotherapy and avoiding all the side effects of chemotherapy. And the hazard ratio was 0.6. And you can see the overall survival. This was a very impressive and gave pembrolizumab category 1 approval in high expressor PD-L1. So we are looking for another one, semibelimumab, even though this is not yet approved in non-small cell lung cancer. This was mostly used in squamous cell carcinoma on the skin. But this is also show you the same principle. If you have a high expression and you give only immunotherapy versus platinum doublet, you're going to be able to achieve a median survival which is not reached in a very relatively small sample, 283 versus the chemotherapy 280. So this is quite significant. You are not able to reach a median survival after you followed up the patients for more than 2 years. We should remember, in the old days, we were happy to have a median survival of 11 months on the first line. Those were my days of training, which is not far away. In Bauer, if you look at atezolizumab in advanced non-small cell lung cancer with high PD-L1 expression, we also see the same pictures, but at a lesser extent. But again, small samples, and you were able to see actually there was a difference. Now, the point here, it was not statistically significant because of the extremely small sample. It was one who was about 100 in each. Now, we will then ask, what about nivolumab? Oh, I'm sorry. So Nivo, it was tried alone as a first line. It failed badly, and actually it did take a hit on the company itself, even though Nivo was the first licensed product as an anti-PD-L1. So actually the company came back and actually did very interesting series of studies trying to bring Nivo to survival. So they did Nivo with the combination ipilimumab, then actually they did Nivo alone, and they did actually histology based. And you can see those big studies has been done because Nivo has fall short from achieving survival benefit by itself. So in this study, actually, the Checkmate 227, they did in the stage 4 with recurrent non-small cell lung cancer and no driver's mutation. So if you have a high PD-L1 expression or a low PD-L1 expression, and then you have a 3-arm study. Now you can see the complexity, then actually they merge every arm for the full analysis. Obviously, if you have a Nivo ipilimumab, you are going to be able to achieve a significant point compared to the chemotherapy or Nivo alone. And that's why this combination has been approved on the second line setting. And so what about if actually we did a combination of immunotherapy with the chemotherapy? Would that do better? Now, obviously, you might imagine those trials has been done concurrently and people were throwing everything at the same time because everyone would like to achieve a positive result so they can take part of the cake. Non-small cell lung cancer is #1 killer cancer across the world, still till now. So this was an open label Checkmate 9 LA trial. And actually they have been certifying the patient with the PD-L1 expression, and we have a stage 4 recurrent non-small cell lung cancer with no driver's mutation. And they have been randomized to Nivo ipilimumab with the chemotherapy versus only chemotherapy. And you can see Nivo was able to achieve an overall survival at 45 versus 32 at 24 months with a hazard ratio at 0.67 significant p-value. So to summarize, so with a high expression of PD-L1, you can see actually the overall response is anything ranging between from 45 to 40%, with the median progression-free survival is between 7.7 to 6, 8.2 to 6.7. And the median overall survival, and most of those trials actually were in the first line, you are running in the range of 20 months. So this is quite a very advanced. Now, always going to become the topic, what's the definition of a high expressor? And this is, you need to talk with your pathology department, because every different antibody does come with its own verification kit, which is approved by the FDA. Now, Bembro is taking the major portion of the whole non-small cell lung cancer cake, because as you might imagine, if you are a hospital, it will be good to have a drug which can use it as a first line, second line, in case you have those cases, plus other cancers. So Keynote 189, they used actually Bembro in combination with the chemotherapy versus chemotherapy. And again, they showed benefit. And then they looked at risk stratification, looking at different expression. With the high PD-L1 expression, they almost were able to achieve the same result when they tried the Keynote 24. So this is just to tell you, chemotherapy probably improve your overall response if you have a high expressor. So chemotherapy does the damage, then you prime your immune system for controlling the cancer. So you can see Bembro with the chemotherapy, the median survival, the other end was not treated. Now, the same design almost went with atezolizumab and paclitaxel and bevacizumab. Now, obviously, this combination has been chosen by Roche, which is controlling atezolizumab and bevacizumab. And again, this did show actually a clinical significance. And keep in mind, those are extremely small studies. Now, the p-value was not significant, so they actually could not claim there's an overall survival. But this is one of the acceptable choices. But the trial was extremely small to show a difference in overall survival. Now, this is just showing you, if you do the analysis based on the PD-L1 expression, it's going to be a clearer benefit with that. So chemotherapy with immunotherapy, we are seeing across the same result, that actually you are going to be able to show an hazard ratio on the range of 0.6 to 0.8%. Keeping in mind, the study's design was extremely small, anything from 150 to 80 patients per arm. In the old days, this used to be 800 patients per arm to show a benefit of 5%. Now, again, another study, but this is actually done on squamous cell histology, and we are going to be able to show. Now, people always had that squamous is more aggressive, which is more like an urban myth than the non-small cell. Than the non-squamous histology. But again, we're going to be able to show that chemotherapy with the with the immunotherapy is showing benefit more than the chemotherapy by itself. And that's for anyone which is expressing BDL1. If you have a high expression, that will be even clearer actually on the overall survival and the hazard. Now, what will happen if you have less than 50%, anything from 1 to 49%? So again, the same option will stand, but the benefit will be slightly lower. If you use actually pembrolizumab versus chemotherapy, actually this study did not show any benefit, but typically people will use a combination of immunotherapy and chemotherapy in this. And this is just to show you the FDA pooled analysis for the first line chemoimmunotherapy versus immunotherapy in patients who have a moderate expression of PDL1. So this is the overall meta-analysis. This is individual patient analysis. And it shows you that the chemoimmunotherapy will have a median overall survival of 21 months versus immunotherapy alone, which is 14 months. So in the one which is expressing that 50%, the indication is for immunotherapy and chemotherapy. And again, this is looking for non-squamous and squamous histology, and it does come with the same conclusion. So it's just like for the sake of the time, I'm just going to skip that to, so this is actually showing the same old study, which is, we talked about the CM9LA, but this is looking at the moderate expression, and you can see ipilimumab with the chemotherapy is able to show actually survival benefit with the hazard ratio. So this is just to summarize actually that immunotherapy option for BDL1 negative advanced non-small cell lung cancer, moderately expression of non-small cell lung cancer. So you can see there's a survival benefit for the combination, and it does actually range from 18 to 17 months. And this is across the board for the squamous and the non-squamous. Squamous is slightly lower. Now, if you look at the NCCN guidelines, so you can see actually typically we will treat the patient who have a reform status from 0 to 2. And the preferred option, if you have a high expression more than 50%, to use Pembro, Atezo, or Similimumab to be used. Now, the other combination of chemoimmunotherapy is also okay. Now, for the squamous cell histology, you can use the pembrolizumab, carbo with the pembrolizumab, chemotherapy with immunotherapy. If you have a moderate expression and you're looking at adenocarcinoma, so you can use chemotherapy and plus immunotherapy, and the other regimen will be using carbopaclitaxel with atezolizumab. For squamous cell histology, will be the carboplatin with pembrolizumab. Now, obviously, if you have less than more than 2 performance status, this supportive care will be probably the best one. So in conclusion, BDL1 expression, advanced non-small cell lung cancer, single agent might be adequate. Combination chemotherapy will be more appropriate for the one which have moderate expression. Even though there is still some minimal benefit for the one which does not express BDL1, chemotherapy will be the standard of care. But we are still learning to predict who's going to be responding in a perfect way and how to better use the immunotherapy across the different stages for non-small cell lung. And with that, I'll go.
Yeah, mashallah. Thank you so much, Prof. Khalid, for this extensive review about the immunotherapy for lung cancer. So we'll open the floor now for questions, and maybe I will start the question for Professor Khalid Saleh. So what do you think about the future for liquid biopsy or the biomarkers for lung cancer? I know that you have you're a leader in liquid biopsy for the breast cancer now at King Saud University.
Thank you actually for this question. That's an excellent question. So one of actually I shouldn't say, one of the early applications for liquid biopsy right now is colon cancer and lung cancer. And actually, the beauty of this has already been verified in a very large trial. So typically, we use the liquid biopsy looking for driver's mutation. This already has been approved for EGFR, so using this with sensitivity up to 70%. Now, it's always the debate about there's many times you cannot obtain a proper tissue, or that it's a very small sample that's going to get exhausted quickly. So the only way we're going to be able to do checking for the molecular testing, which is so essential in lung cancer, is through the liquid biopsy. So liquid biopsy is good, but it's not for the BDL1 expression. It's looking for driver's mutation. It's mostly done when you have a non-squamous cell histology. And this is the biggest role. And fortunately, it is available here in the kingdom, and you can obtain it within the result maximum by week, you can get the result for that. So it is essential just to rule out the presence of a driver's mutation. But the BDL1, unfortunately, we still need to use it on a tissue, not.
So do you think that we are close now to have it, or?
No, we have it actually. So we have it. Now, unfortunately, sometimes it is intermittent because there's a special tube you need to collect it. So you need to collect it in a special tube. So it will be sent to the lab and processed before they're going to send it for the final thing. But it is available and we have it at least in KQH.
Excellent. Thank you so much, Prof. Khalid.
Welcome.
Okay, so we'll see if there is any other questions. I see a question. Maybe this is for Dr. Ahmed Bamousa. Do you recommend segmentectomy in stage 1 or lobectomy when mediastinum wasn't explored? Dr. Ahmed?
What do you mean by not exploring the mediastinum? If we are talking, let me answer it in another way. If you are talking about a small lesion in the periphery of the lung, that is adenocarcinoma less than 3 centimeters away with no mediastinum and the PET is negative, then yes, go ahead and do the surgery. But if the lesion is centrally or it's more than 3 centimeters in size peripherally, then you have to do the mediastinal staging. And the mediastinal staging at this stage will be EBUS or US, and that actually to confirm if there is an N2 disease. And if it is N2 disease, this patient will go for neoadjuvant therapy, and then he will restage the patient by mediastinoscopy. And once it is negative, you go for surgery. And then during the surgery, you have to biopsy those lymph nodes, and you have to take 3 stations, subcarinal plus 2 mediastinal lymph node, as well as 3 intrapulmonary stations in order to accumulate the disease. Whether you want to do a segmentectomy and you are efficient in doing that, go ahead. Again, the recommendation up to date is to do a lobectomy. You are not, unless you are mastering that and you have a safe margin. And the talk about the tumor spread through the airway disease is ongoing now, and we don't have a way to confirm it. So I prefer to go for a lobectomy rather than segmentectomy.
Just to add to you that when you do the segmentectomy, please be sure that you're taking the lymph node adjacent to you, like station 12 and 11. And if it is positive, then you have to convert to a lobectomy.
And please make sure that the margin you are going is more than 2 centimeters.
Great, excellent. Thank you, Dr. Ahmed. I think the next question it's for Saleh Boudef. Does persistent into single station disease preclude the surgery?
So that's a fantastic question. If you think that it is not bulky and it is still resectable, then you should consider doing the resection, again, provided it is not a pneumonectomy or extended pneumonectomy. And my approach for these cases is I explore thoracoscopically and I target the lymph node first. I don't dissect the hilum. I don't go and do lobectomy first and then do the lymph node dissection. No, I start at the lymph node. If the lymph node doesn't come out, then you should stop, because then you're not going to get negative margins there. You're going to find positive in the lymphatic channels. So target the lymph node first, completely resect it, then continue with your planned resection.
Okay, thank you so much, Dr. Saleh. I see a note here from, actually comment from Prof. Dawlatli. He's a professor of anesthesia at King Saud University. He's actually the guy that we cannot work without at King Khalid University Hospital. So yes, anesthesia is thoracic anesthesia is very important part of our job, and we will not succeed without having a good thoracic anesthetist with us. So thank you so much, Prof. Dawlatli, for this comment. So there is a question from Pierre Youssef. Can you please repeat the difference in lung function between segmentectomy and lobectomy? Maybe this is for Dr. Ahmed Bamousa.
In that study, looking for the phase 3 trial, they found that those patients, it was expected that those patients going for segmentectomy will have a better function rather than those patients with going with lobectomy. And surprisingly, it was only 3.5 reduction, the forced expiratory volume 1, favoring the segmentectomy than lobectomy, which is not that significant. That's actually the result of the study.
Okay, excellent. I hope this is clear for you, Pierre. So is there any other questions from the moderators or or anyone on the floor?
Dr. Saleh, I see a few attendees, they are raising hands for questions. So
Okay.
kindly, if we can instruct them that they can type in their questions and hopefully they will be answered
I
shortly.
didn't see them. Yeah, please. So anyone have a question, please type it in at the question and answer part, so we can ask the question and answer it.
Yeah, I received a question. I just would like to, I wrote the answer, but it's not complete because it's such a broad question. I'd just like to highlight. The question is there any difference in operating between a single station and two between the right and the left? And the other question is, what is the precaution you would take in advanced lung cancer abutting the aorta? So that's a two-part question by Samir al-Salahi. And so the answer for that is there are many differences between left and right, but as you saw, stations 5 and 6 are harder to approach preoperatively and to assess. So you might want to use VATS for that because EBUS might not help you. Overall, if it's left upper lobe, they do very well if it's 5 and 6. They don't do very well if it's left lower lobe. Station 7 overall as a lymph node, whether it's right or left or upper or lower, is a bad prognostic. This has been shown since the 80s by Naruke and has been holding up in the Japanese Collaborative Oncology Group as the lymph node that doesn't do well. And the reason for that is the embryological drainage of station 7 comes from both sides. So therefore, if you look at it, it follows the bronchial arteries. So most of the drainage is right-sided versus left-sided. So you don't know if this is actually an N2 or N3. We have no way of testing, but anatomical studies show that this lymph node has very variable drainage in the population. So station 7 is generally worse. Regarding the approach to the aorta, if your patient comes in with a vocal cord paralysis, they come in with a hoarse voice, that's generally considered inoperable. That's a clinical exam that precludes, even CT scan. You know immediately that there's something fixed and invasive at the 8P window because that's where the nerve would be. So that's one of the things that you have to look at. You should consider doing other tests like MRI. And if you're doing them intraoperatively, you should be very careful. I haven't been in a position where the aorta was a problem with lung cancer. I have been in a position where the aorta is a problem with esophageal cancer and posterior mediastinal tumors. I work in a center, is the cardiac center, so we have an access to a perfusionist and a vascular surgeon in the OR at any time I need it. But that's not the setup in most centers. So if approach the aorta with a lot of caution. That's what I would say for any tumor abutting the aorta.
Okay, great.
Can I add something for Dr. Abu Daf?
Yes, please. Go ahead, Prof.
The case that you present, although some people will consider, the left upper lung mass with the upper mediastinal lymph node, actually some of the people will consider those lymph nodes as in one disease, not as a mediastinal lymph disease, because it's a direct communication. I totally agree with you about your approach of taking it as sampling and then go ahead and resect it, which is an excellent approach. But I'll still consider those as in one disease, not as an include.
Absolutely. You're actually correct. The 6th edition and 7th edition cases showed post-operative cases that were positive at 5 and 6 behaved almost as stage 2B. So they're downstaged one stage. But those are cases that are retrospective data, and it's cases that have been already resected. So it's subclassification, ACCP subclassification of N2-2, not N2-3 specifically. But yes, one of the reasons I was very active in that case is because I know they do well. If it was station 7 that was positive, they don't do well. So, my enthusiasm for it was exactly what you picked up on that perfectly.
Sorry, I didn't get that, but do you consider station 6 and 5 N1 or N2 disease?
They are technically N2.
Yes,
you cannot say it's N1. However, the regionality of the drainage, if the anatomical regionality of drainage is consistent for 5 and 6 for left upper lobe in a way that it's almost higher. Now, let me be very careful how I say it. I'll give you another example of it. If you look at Pancoast tumor with scalenus lymph node or subclavian lymph node, those are technically N3. However, if you resect them, they behave as N1. And N2 behave as N3 in Pancoasts, the one with direct invasion, not the ones that are superior sulcus. And that's been consistent in superior sulcus data in multiple groups. Like I said, not all N2 are created equal. 7 for me is the worst by far.
Yeah. Okay, great. No, I agree with you that N5 and 6, there is a lot of, like some studies actually, they said that they behave as an N1, but still, I want everyone to know that it is considered as an N2 disease. So not to confuse the picture. That's it.
Absolutely. My feeling is in the future, if you're going to look at multiple N1 as being more dangerous than N2, that's what the data suggests.
Excellent. Okay, so maybe now I want to ask Professor Khaled Qattan about the lung cancer screening, the program that they initiated at the university. So, how's it going so far?
Yeah, thank you very much. I think it's quite important. We talked about management of lung cancer, and Dr. Soha highlighted very much the importance of starting screening. Now, as probably she said, when we worked with the NIH, National Institute of Health in Saudi Arabia, they elected to focus on 3 cancers in the oncology: breast, colorectal, and lung. And among the questions is the true incidence and the value of screening. So really, we need to have a national or at least regional data enough to implement screening and see its benefit, and also select our criteria that may vary from the international one. So what we did is we had a lung cancer screening interest group with the oncologist and radiologist. We did put a protocol as for lung cancer screening, and we actually looked for fund. We are now in the final stages of getting a good fund from one of the companies. And meanwhile, we adopted a protocol that we all agreed on, starting in 5 hospitals within the kingdom. They will be initially starting with the family and primary care, and then goes to the each hospital IRB so that they can become recruiting patients. I think once we start, we will be recruiting more centers. So from the audience or from the respected panelists, your hospital will be invited at one stage into that. We want to make sure that the protocol of the low-dose CT scan is done correct. We have Dr. Masha'al, consultant radiologist and cardiothoracic, is leading this. And we will start be collecting this data. I think this will help us a lot to see is whatever applied in the 2 trials is applicable to us. It is cost effective. It improves patients' outcome from lung cancer, both quality of life and mortality. I think Dr. Soha, with her enthusiastic approach, and King Khalid University Hospital probably will be invited to that. And we have also Dr. Khalid Saleh from King Saud, also eminent oncologist. So I'm sure we can have a multi-centric national trial, and we will get the results. Unfortunately, this will at least take 3.5 to 4 years, because you need to do year 1, year 2, and then year 3.5 or year 4. And at that we can do. So too early to talk about it, but it is in the way. And once we announce it, those who are interested will be welcome to join.
So thank you. Do you think, Prof, that the inclusion criteria will be similar to the same what we have like in the international guidelines?
You see, even today, the international guidelines are being questioned, because we are seeing more cases of adenocarcinoma, younger age, female, non-smoker. So really no one would have this answer correctly. But I think as a start, we are almost using the international guidelines, that it is there, because this is what we call higher evidence level. But there is other trials happening to include younger age group and non-smokers into that, yet no data is available. So it's very difficult. I think once you start something like this, when you don't have enough data, your best chance is to use and benchmark other international studies, despite knowing there might be a variation, but then your result of your study will elaborate on this variation, and then we can readjust for the future.
Great.
So, thank you so much for your input. I was looking forward for this complementary part to my topic. I just have a quick question for you, please, because I have this interest in this in the lung cancer screening, and mashallah, you're an expert, you and your group. So you mentioned that there are 4 hospitals that are included already in your project. Do you see this project including being all over Saudi Arabia, or it's going to be more Riyadh oriented? And the other question, do you see if it's in the future, inshallah, when it has most of the hospitals across the country included, do you think it should be under the Ministry of Health, or it's going to be centered around Al Faisal University as well?
Yeah, I think the first part, yes, I think we want more hospitals to be enrolled, not necessarily Riyadh, not necessarily 4 or 5. I think the more we have, the better. But there will be criteria for centers who want to enroll, one of which the volume, and number 2, the availability of the required investigation, and the availability of the technicians and the technical and clinical staff who can perform. So the answer is yes. Now, who owns it? This is a big debate. Today, I was in just accidentally, I was in the Global Health exhibition, and we had a parallel session about radiology, and I was asked to talk about guidelines. And the problem, and we used lung cancer screening guidelines as an example. And we had people from Ministry of Health, a person from Saudi Health Council, and a person from the private sector, a person from King Abdulaziz University Hospital, so his university, and a person from King Faisal Specialist Hospital, and then a person from the Saudi Thoracic Society. And there is also people sitting with the Saudi Oncology Society. So the problem we have, I think, in Saudi is the ownership and the role of each entity, whether the Ministry of Health will own it, or this should belong to the societies. And then once it is out, it endorsed by the Ministry of Health and being implemented or forced to implement by the Ministry of Health and be governed by the Ministry of Health. So I believe personally that such a mega project, if it goes on, should be coming out of the Saudi Thoracic Society in association with the Saudi Oncology Society, and then be endorsed by both Saudi Health Council and Ministry of Health, then be distributed and implemented. And then when the data comes, this becomes evaluated, and then regulatory part based on the results of data should be implemented by the Ministry of Health. But the ownership, I really recommend that us, me, you, Dr. Khalid Saleh, the oncologist, the radiation therapist, the surgeons, and all other members who deal with lung cancer and are technically expert in this, should be the team who puts these guidelines, review it, and give recommendation. And the role of Ministry of Health should be governance and implementation.
Thank you, Dr. Ghassan, and I'm looking forward for the invitation to King Khalid, inshallah.
Okay, excellent. I don't know if we have any questions or not. I think we're good. So, Prof. Yusuf, you can.
Assalamu alaikum. يعطيكم العافية. يعني it is one of the best webinar in the 2022. I attended the Society of General Surgery, and you have the highest number of attendee, 410. Congratulations and thank you, everyone. We put here our monthly meeting. Inshallah, next month we'll have the breast webinar. We'll talk about the breast cancer. Then we have the hernia in November, and the laparoscopic in November also 24. Then obesity, and finally we'll meet the American College of Surgeons Saudi chapter, inshallah. I want really to thank Dr. Saleh Nasser and all the moderator and the speaker for the great webinar. Also, I want to thank Cobra and Asim and the sponsor company really for very nice and interesting and succeed of the webinar. Thank you, and we'll see you inshallah in 30 of October, inshallah. Thank you very much.
Excellent. Thank you so much, Dr. Yusuf. So also, I don't want to forget to thank Cobra and Asim for their tremendous actually efforts with us. They are the one who are organizing everything actually and taking the whole headache. So at the end of this webinar, I would like to thank again the Saudi Society of General Surgery and Johnson & Johnson for their support. Also, thank you to all the moderators, Dr. Ashraf, Dr. Walid Saleh, Dr. Khalid Qattan, Dr. Khalid Saleh, Dr. Saleh Abu Daf, and Dr. Ahmed Bamousa for their efforts today. And hopefully we'll meet again, inshallah, in other thoracic surgery events. So thank you so much and good night.
في أمان الله.
في أمان الله جميعا.
Thank you.